Good afternoon. It is my pleasure to introduce Professor David Lomanto, Senior Consultant, Bariatric and Metabolic Surgery, Robotics, Department of Surgery, National University of Singapore. He is no stranger to Sri Lanka. He has visited us on many previous occasions. He's performed live laparoscopic surgeries here, and he's also person who organized the ELSA program with our Department of Surgery, where many trainees have gained the necessary skills in basic laparoscopy. Over to you, Professor Lomanto.
Thank you, Ishan. It is a great honor and privilege to be here. I need to thank all the board of the executive committee of the College of Sri Lanka, and especially my good friend, Professor Sam, for the kind invitation. So we will talk about bariatric surgery. I'm not so sure if it's a problem in Sri Lanka, but I believe that it's developing and moving towards transitional economy. I think obesity is going to increase all over. It's a faster growing, but the most important thing is that not in all countries is considered a disease. That will affect also the treatment sometimes and the management of those patients. So it's predicted to grow further, and what we have seen, especially in Asia, an increased rate in a young population, especially in children, in adolescents. And of course, the prevalence is increasing all over the world. We expect about 300 million of obese patients that need surgical treatment, and obesity comes also with comorbidity, and comorbidity affect the healthcare and the economics of any countries. And you can see how obesity will be almost 40% in terms of incidence in developing countries. But what is mostly, you can see from the slide, not only the developing country, but the so-called economy in transition. So when a country moves from being in a poor level to more developed countries, so when the status, the middle income increase, the rate of obesity increase at the same time. You can see how Asia is the highest rate of transition and developing country will have also increased risk of obesity if we look at China, for example, and we look at other countries. And there is also something to understand that the situation is not reflected in the economy in transition and developing between rural area and urban area. The obesity is more seen, of course, in the urban area where the economy, the middle income is higher compared to the rural area. So there is an imbalance sometimes even within the same society. So it's hard, it's affecting Asia, and Asian people are getting fat and growing faster. You can see, for example, in Malaysia, how the obesity almost affects 44% of the population. Philippines probably is the second one, but you can see even in Singapore, that is considered a developed country, the obesity is growing, and we have almost 16% of obesity in adolescents. Single child, especially, are over-nurtured by the parents. So while still in countries that are still behind and still continue to maintain the original soya bean diet, is still under control, like Vietnam, like Cambodia, Laos, and so on. While Thailand, Indonesia, Malaysia, Philippines are the highest one. So why? Too many shopping centers. Everybody wants to park and race to park closer to the escalator. Nobody walk, so reduce physical activity, increase consumption of energy-dense food, fat-saturated. So the policy that most of the government abandoned in the 50s, 60s of the soya bean diet to increase, of course, the nutritional status of the children have brought a big impact. So we are still lucky in Asia that there is still the A4 waistline obsession. I don't know if you are aware, there's a lot of, few years ago, before COVID, a lot of discussion, especially in China, of the woman to get married, they need to have this A4 size waistline. But as I say, this is something that is increasing today, obesity among the children, and you can see it's growing all over. And it's almost the range about from between 10 to 12 to 14%. So increasing, of course, increase also the future. So when they are adult, they are not going to slim down. So obesity, as you know, carry a lot of comorbidity from diabetes, hypertension, reflux, increased risk of cancer. I just came back from IFSO. One of the main sessions was the relation between obesity and colorectal and esophageal cancer that is already very well demonstrated, but also the diabetes. And we do know that in Asia, in some countries, we have the highest rate because of depletion of insulin, because of other factors compared to the Western country. And I pass by Delhi airport and the people shop metformin with a trolley like in the supermarket because it's very cheap. So highest rate, almost 60% of the population. But why? Because greater BMI carry very high risk of comorbidity. You can see here how this is a study in Singapore, how the comorbidity increase with the BMI. And also because at the same BMI, Asian population carry more fat. And I'm sure you are familiar with the type of obesity, gynecoid or android. In Asia, we have especially more android obesity, so central obesity that carry the highest chance of diabetes. So at the same amount of BMI, we have more intra-abdominal fat. That's why our indication for surgery are lower than Western country. Instead of 35, 32.5, instead of 37 without comorbidity to 37.5 to 35. So that's are the changes and the risk. Why? Because more than obesity in Asia, we have a so-called more a metabolic surgery. So if we look at the treatment of obesity, we all know that surgery is the only successful surgery. At least we can achieve a good excess weight loss in more than 65, 70% of our patients. There are some regained weight, like in any procedure, there are the downside. So we want to monitor not only the procedure, but also the type of procedure that we do. And this is was one paper that I did in 2005, 2008 with our society. And you can see in 2009, in Asia, we do only 6,500 obesity procedures. If you consider in my hospital and in all over, in our clinic, we only only 1% of the people that come to our clinic are agreeable to do surgery. Most of the obese patients refuse surgery. So the trend was, at the time, 2009, there was a decline in adjustable gastric bandage that was very popular, and there was an increase on the sleeve gastrectomy, but also Roux-en-Y gastric bypass and the mini gastric bypass was slightly increasing. So we redid after 10 years, and we noticed that the number of cases of bariatric surgery was going to increase. But the main interesting thing is that many countries recognize obesity as a disease. At least 10 out of 15, no more a cosmetic disease, but a pure pathological disease. But only 3 out of 17 countries recognize the metabolic disease. We know that bariatric surgery correct diabetes in 65-70% of the diabetes patient, especially if diabetes is less than 5 to 6 years from the onset of the syndrome. So Countries like Japan recognize only sleeve gastrectomy, not other procedures, and compared to other countries. So the number of operative procedures increased 60 times more, from 6,000 to 41,000, and also the number of surgeons that were trained in bariatric surgery. But this is also comprehend mostly Middle East countries. So the type of procedure were still gastrectomy, about 70%, no more adjustable gastric banding, and the bypass was stable about 20%. This is the growing number from 2,700, 3,000, 2003, up to 95,000 in 2018. And the procedure shift from adjustable gastric banding to LSG. You can see in this left side, you can see the data in 2010, and you can see in 2020. And you see, for example, Taiwan from 1,000 cases to 3,000 cases, China from 600 cases to 15,000 cases. So big increase. But still, if you consider that we have 4 billion population, it's still very, 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 very low. So the procedure trend was this one. And this is the latest, IFSO is the International Federation of Obesity Society. If you see in the Asia-Pacific chapter area that comprehend from Middle East to Japan, we see this interview, we see a prevalence of reduction of sleeve gastrectomy at this point of view, an increase of OAGB, probably because a bypass with malabsorption is more effective on metabolic syndrome, even though the sleeve gastrectomy is effective in cure diabetes, but a bypass gives you more guarantee in the long-term run. So because of the metabolic disease that we have in Asia, there is more change towards the one anastomosis bypass, is kind of B1. But if you look at the data that I want to focus mostly, you can see that most of the country today, they have a guideline. I don't know the situation in Sri Lanka because we don't have data. And for example, because of the high incidence of gastric cancer, especially in East Asia, Japan, Korea, and China, also in Singapore, we do perform routinely gastroscopy intra-op. And then that's why on one side, we do less Roux-en-Y gastric bypass because we cannot monitor the left stomach. And it's interesting in the last column, you can see the reimbursement. Most of the country consider now bariatric as a disease, so there is a kind of reimbursement, partially or total reimbursement for the procedure. So the number of procedures went up, same, about 70,000. You can see still number one sleeve, OAGB about 15,000. This is a big jump for that. What are the issues of bariatric? So today, I think insurance healthcare system, in many countries, recognize and adopted obesity as a disease because they can save money in future medication for hypertension, for diabetes, and hypercholesterolemia, OSA, and so on. But still, we have a lack in training. We have also lack in awareness, especially among the general physician, endocrinologists, that very resilient to refer bariatric and diabetic patients to surgeon. So the number of experts are still very low. And of course, the situation between urban, big academic center and the rural area is different. And then we have a lack of accreditation system for each country. So in conclusion, I think bariatric surgery, metabolic in Asia is growing very fast. They change in procedure because still we haven't found probably the gold standard, but we are adapting to the local situation. As I say, it moves faster, more than obesity as a metabolic cure for especially type 2 diabetes. And there are many treatment and innovation that are coming because, for example, we have started to do endoscopic gastroplasty. We have started to do many other procedures, including, as you know, medical therapy with the GLP-1 inhibitor give excellent result. in patients that don't want to go to surgery, we can still achieve about 10, 15, 20% of excess weight lost in 6 months, 1 year. Anyway, we are very well connected in the world, so we play a big role also worldwide. Thank you very much. Anybody want to download free, the student, our book? We have more than 700,000 downloads. It's a ELSA Society published the book. Only the cost of making as open access for all surgeon, resident, and medical students. Thank you very much.
Okay. Thank you, Prof. As this is a plenary lecture, there's no time allocated for questions. Let me thank in the traditional way. Thank you very much.